Support for this episode comes from US Med. US Med sets the bar high when it comes to diabetes care. US Med excels in customer satisfaction, ranking number 1 in Dexcom customer surveys. And online, they're number 1 in Google and Facebook customer ratings among large national diabetes DMEs. With over 1 million satisfied diabetes customers since 1996, they've perfected the art of delivering better service and better care. From insulin pumps to diabetes testing supplies and the latest CGMs like Freestyle Libre 2 and the Dexcom G6, they've got you covered. Plus, they accept Medicare nationwide and collaborate with over 800 private insurers. US Med, your trusted partner in diabetes care. Your health, satisfaction, and peace of mind are their priority. Visit usmed.com/Stacey. That's usmed.com/STACEY. Today on Diabetes Connections Type 2, getting a CGM is more and more a routine part of a diabetes diagnosis. But figuring out if your insurance will pay can be anything but routine. A new pilot program is recruiting pharmacists to be a big part of this process, helping educate patients about their options, even writing prescriptions. Plus, with all the talk about continuous glucose monitoring, you may have heard about time in range. What is that, and why is it inching out A1C as a gold standard measurement? This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Hello and welcome to another week of Diabetes Connections Type 2. I'm your host, Stacey Sims. I'm really glad you're here. For more than 8 years now, I've hosted another podcast for people who live with type 1. There is some crossover between these two shows, but I think there are enough differences to have a brand new podcast. And continuous glucose monitoring is one of these issues that sort of bridges the two communities. But at the same time, I think there are issues and ideas specific to type 2 when it comes to CGM. And we're going to talk about that today. One thing I do hear from the entire diabetes community is that there just isn't enough education. We get so little time with our doctors, most of whom would love to spend more time with us. So every episode of this show will feature just a little bit of diabetes education, facts, or concepts. And since we're talking about CGM this week, let's get into it. We're going to talk about time in range. Time in range, pretty self-explanatory, is the percentage of time that a person spends with their blood glucose levels in a target range. But the range can vary, depending on the person, depending on their doctor. In general, the guidelines right now are a range of 70 to 180 for blood glucose. Most people measure this as a percentage, 50% time in range. But you can also look at it as time, as hours. So that 50% would be 12 hours a day. For the last 40 years or so, A1C has really been the gold standard of average blood glucose measurement. We've explained that on a previous show. It's an average blood glucose number from 2 to 3 months. It doesn't give any nuances. It doesn't show you any ups and downs, certainly not throughout a day. One of the limitations of A1C that's commonly pointed out is that you can have a number, let's say A1C of 7%, and that could mean that you're spending all your time right at 7%, or it could mean that you have a lot of highs and lows that cancel themselves out and give you that really good sounding average. Doctors are just beginning to come to a consensus about time in range because it is so new. But right now, most recommend aiming for at least 70% time in range of every day. Again, that's 70 to 180, and less than 4% of the day below 70. That's the goal. It is worth noting that in large real-world studies, time in range is typically around 50 to 60% in the average person with any type of diabetes. Every commercially available CGM has a time and range calculator. There's a setting in there, there's a screen in there that shows you how much time you're spending in range as a percentage. So if you've got a Dexcom, if you're using a Libre, there should be a simple way to find that. Again, we're in early days with this. Health insurance companies, the FDA, are still figuring out what they want to do with time in range. A1C, like I said, has been around for 40 years. But there is something called the Time in Range Coalition that is looking to study this more, spread the word, and advocate for it. And you can learn a lot more. There's a lot of good information out there on this. In the show notes, I'm linking up to a wonderful article on Diatribe that explains time in range and also has a lot of links to studies and graphs and lots of really good ways to explain it. Okay, my guest this week is Robert Nichols, a clinical pharmacist based in Waterloo, Iowa, who helped develop and is taking part in that pilot program we're talking about. The American Pharmacists Association Foundation, with support from Helmsley Charitable Trust, created this program. And here's what they say about it. It is to expand access to pharmacist-provided CGM devices and services. The first of its kind pilot program will empower community pharmacists to prescribe CGM with the ultimate goal of increasing access to this critical tool for diabetes management and care. While many patients with diabetes may not even have access to a primary care physician, the average person interacts with their community pharmacist 12 times more often than their primary care provider. And you'll hear from Robert Nichols right after this. It can be pretty tricky to travel with insulin, especially if you're going somewhere very cold or somewhere very hot. We have found something that really works well for us, and that is the VIVI Cap from Tempramed. It keeps your insulin at the exact right temperature, even in the extreme heat or cold, and it works for any insulin pen. Super simple. You just take the cap off your insulin pen and you slide the VIVI Cap on. No batteries, no charging, no water or ice packs. It lasts for years and gives you 24/7, 365 protection because insulin is very temperature sensitive. VIVI Cap has a 30-day, 100% money-back guarantee, and it's got a 2-year warranty. Find out more. I've got a link in the show notes for you, or you can go to diabetes-connections.com and click on the Tempramed VIVI Cap logo. Dr. Nichols, thank you so much for joining me. I appreciate you spending some time to explain this. Thanks for being here.
Glad to be here. Thanks for having me on.
You got it. Before we jump in and talk about the Helmsley program and, CGM access and all of that, would you mind taking a moment and just explaining your job? Because I think we think of our pharmacists as you're just putting pills in a bottle. It is so much more than that. Tell me about your day to day.
Yeah, thank you. And thank you for characterizing that way. Because in the general public, we tend to have a certain perspective or perception of what a pharmacist is. But as you mentioned, pharmacists do a lot of things around medication therapy optimization and medication safety. My job at the pharmacy, my title is Director of Clinical Operations. I work in an independent pharmacy in Waterloo, Iowa. I'm part of a small group of independent pharmacy, about 5 pharmacies. But essentially what my role is outside of the dispensing workflow is to work across many disease states to help people be as knowledgeable as they can about their medications, know how to appropriately take them, and then know how they should be monitoring whether or not that medication is working well for them or if they're experiencing any side effects. So specifically as it relates to diabetes, we work really closely with our patients. We work really closely with our providers in the area to make sure people are able to monitor their diabetes numbers and metrics to the best of their ability. They're able to gauge whether a certain new medication or medication they've been on for years is the best and is working to improve their diabetes situation, but then also making sure that any medications we're starting or combinations of medications that are coming together are safe and effective for that person. So it's a lot of tinkering here and there and having face-to-face encounters with people and talking through their diabetes management.
I remember when my son was diagnosed at the end of 2006, and we got all of these prescriptions, some of which could be filled to the pharmacy, some of which we had to do mail order, which I had never thought about back then. I was overwhelmed. I went to the pharmacy and I said, "Can you help me?" I didn't even know my pharmacist's name at the time. Now we're best friends. But I was like, I don't understand what any of this means. Can you talk a little bit about how you interact with and I know it may be different for type 1 and type 2, and that's okay. We can talk about it all. But how you interact with newly diagnosed patients who have diabetes?
If somebody's coming to us newly diagnosed in diabetes, we recognize when we're filling prescriptions that either we haven't filled them before or we filled medication before, but these are their initial diabetes medication. We really make it a point to take the time to sit down with that person in one of our private counseling rooms to go through what it is that they're going to be, working with for the foreseeable future. It's really challenging getting a diabetes diagnosis. There's so much that goes along with not only taking the medications, but then doing the ongoing monitoring to make sure that different body systems in your body are still working well because of the effect diabetes can have on them. So For instance, we obviously will go through any medications that are starting, how best to take it, how it relates to taking it with food and timing of day and so on and so forth. We also like to talk and make sure people are comfortable if they are using CGM, talking through how that process of putting on your sensors and setting up your phone app or setting up your reader kind of works so that it's as easy as possible for the people to use it. Or if it's the old finger stick method, if we're talking testing that way, making sure people understand how to use their lancets to prick their finger, how to use the strips to, to read their blood sugar, what those blood sugar readings mean, depending on time of day, those kind of things. And then really importantly, we also like to stress the importance of visits with their providers and the different types of providers. We're talking obviously your primary provider. If you're seeing an endocrinologist, making sure you're keeping those appointments to have your A1C tested periodically, making sure you're having foot exams annually, making sure you're having eye exams annually so that the person leaves that meeting knowing that diabetes can affect different parts of your body, but that there are ways that we can help protect those parts of the body by keeping regular appointments and monitoring for that person.
Knowing the role that a pharmacist can play, often being the first person someone sees or the most frequent person someone sees, right? We see you all more than we see our doctor most of the time. Can you talk a little bit about what you thought when you heard about this Helmsley Charitable Trust, this pilot program, which allows pharmacists, as I read it, to prescribe CGMs?
Yeah, there are some pharmacies in some states that are allowed to prescribe CGM. Unfortunately, Iowa is not one of those states, but what this program really brought about as we were talking about what this program could look like and how we can kind of put it into operation, it brought together like a team of really brilliant minds to be able to see how we can work through some of the barriers that we've, encountered in the past. So we're able to share ideas about payer barriers, share ideas about workflow barriers. So what does it look like helping people get access to CGM in the pharmacy? What does it look like helping people manage their CGM or understand the numbers that are coming out of their CGM devices? What does it look like to interact with providers, and what different ways can we interact with providers to help take that CGM data and help put this person in a better diabetes situation because of the frequent access that we have to the patient and frequent access that we have to the data. So I was really excited, learning the different ways that we can help the people who needed it the most. In our situation at our pharmacy specifically, it was our Medicaid population patients. We had so many people who have diabetes, were on Medicaid, but the general understanding of CGM in our area and in the minds of our local providers was that, well, if they have Medicaid, CGM's not covered. I mean, it's just not an option for them. But working through this and being part of this process gave me some time and some support to be able to investigate some of those barriers that we had. And it was especially helpful probably about last summer, beginning of last year, closer to middle, beginning of last year, when Medicare was changing some of their guidelines around CGM coverage, and then some of the Medicaid MCOs seemed to follow. And so I was able to learn what levers to pull to get somebody CGM covered under Medicaid. And now I'm glad to be able to say that for anybody who is on Medicaid, I know how to get them access to CGM as long as they meet certain criteria.
We had personal experience with it because when my son was diagnosed, we did finger sticks for a very long time. He was 2. I believe he was 9 years old when he got a CGM, which really just changed everything. In those days, though, even when he first started, you still had to calibrate a CGM. So we were still doing finger sticks twice a day. But we are really in a different place now. Have you seen that evolution? And can you talk a little bit about how it has changed from the pharmacist's perspective, right? Because when I go to the pharmacy now, the meters are like nowhere to be found. They're behind the counter. There's like 2 of them.
Yeah. As far as the evolution of CGM, I'm relatively new pharmacist. I've only been practicing for about 5 years. So
this has always been the case.
And everything.
You've always seen it.
This is what it's been. It's been the primary 2 vendors on the market, and it's been, real time or at least intermittently scanned. Cool. So it's been the biggest thing of it is for me is that it's been there, but it hasn't been accessible to people. So it's like this really cool thing that can make it a lot easier to manage your blood sugars, but either it's cost prohibitive because the coverage by insurance isn't there, or it's there, but it's still expensive for people or too expensive to fit within the budget, or it's just was seemingly not an option for that person because of, for whatever reasons, just flat out insurance not covering it. For me, the evolution has just been from, hey, there's this really cool thing. And like, okay, it started, there were some commercial companies starting to cover it. And then, there was some payers that were covering it, but there was all these barriers in order to be able to get to it. And now we're getting to the point to where those barriers are falling down and it's being recognized, the value that it can save on the total health spend by being able to help somebody better control their diabetes. So it goes from a conversation, at least how I'm perceiving it, is that it's less about the cost for the payers of the product and more about the cost savings it can bring from avoiding very expensive hospital visits that they'll have to pay for, or very expensive doctor's visits that they'll have to pay for because a person's diabetes is better controlled and they're not having to go hospital to kind of get a hold of uncontrolled diabetes situation, which is very expensive for them.
Oh, yeah. There are a lot of barriers to getting all diabetes technology. Can you walk me through a little bit when it comes to CGM? I would think that a couple of years ago, the biggest barrier would be just knowing that it might be available for somebody, let's say, with type 2. How does it work from your end? Somebody comes to you and is thinking about CGM, a doctor calls you. What are some common ways that your expertise, where you're helping people get more access, how does that come into play in a practical way, if you don't mind kind of describing it? I want to tell you about AG1, the daily foundational nutrition supplement that supports whole body health. It makes me feel like I'm doing something good for my body, right? I'm giving it the nutrition it craves. AG1 is a science-driven formulation of vitamins, probiotics, and whole food-sourced nutrients. It helps you build your health foundation first. I get the travel packs, so I don't have to miss a day, and it just tastes great. If you want to take ownership of your health, it starts with AG1. Try AG1 and get a free 1-year supply of vitamin D and 5 free AG1 travel packs with your first purchase. Go to drinkag1.com/Stacy. That's drinkag1.com/STACEY. Check it out.
I think the most valuable thing was understanding the payer landscape and understanding, for me and my staff, we know that if somebody has Medicare, and of course you have different parts of Medicare, you have Medicare, original Medicare, and you have Medicare Advantage. If somebody has original Medicare, I know they just have to have diabetes and be on at least one insulin a day, and they are eligible. So that creates a really accessible pathway because it doesn't require a prior auth. I just have to, as a part of my billing process, identify that that is the case for this person. When it comes to Medicare Advantage plans, it operates more as a commercial plan. So like a standard plan, like you'd have through employer. There can be limited access to that with some payers. But it's easy to find out because really I just have to get a prescription from the provider and process it, and they'll tell me if it's covered or not. So it's very easy to know. I know this one, it's like, okay, if they meet this criteria or not. If it's this one, I know I just have to get the prescription, run it, and it's real-time claims processing. So I'll know right away. If it's Medicaid, I know that we have 2 of our Medicaid MCOs, 2 of 3, 2 that will let it go through as long as they have diabetes. That's it. And I run that as a claim. So no prior authorization process. The third one requires a rather extensive prior authorization process to have us identify that the person is taking insulin multiple times a day. And I have to essentially declare which device I'm going to be doing by saying whether it's going to be real time or if it's intermittently scanned. So basically using their phone to do the monitoring or using the given reader from the company to do the monitoring. How that interaction typically goes, how it started was that we were identifying through running a report in our pharmacy management system to see, okay, who meets the criteria for Medicare? Who meet the criteria for Medicaid? And then the commercial people really just kind of filter in because we were looking at, okay, where's our low hanging fruit? Where can we start? Where is the highest need? And typically the Medicaid population is really high need population. So from there, we were able to, again, we have lots of touches with patients. We were able to work with our workflow to say, okay, when this person comes in, we can have this conversation with them. We know you have diabetes. It looks like you're testing using your finger sticks. Would you be interested, if your doctor was okay with it, if we tried to get you access to the monitor on your arm? And pretty much everybody said yes, because it's like, oh, this is a thing. We can actually have this stuff. So it was almost always a yes. Then from there, we put in a call to the doctor and say, hey, this person looks like it's eligible. Their insurance covers it. Would you be willing to send the prescription for one of the other monitoring devices and the different versions of the monitoring device, depending on what payer we're working with, just so we can have some flexibility. If one not covered, we can just flip to the other one, so we're not having to call the doctor and say, hey, that was the wrong one. Can you send a different? Wow. So we're working into our workflow some flexibility. But then it's just working through the payer billing process and then calling back the patient, having them come in when they pick up their medication, doing the education on how to use it, and setting up follow-ups to see what the numbers are telling us.
It's such an interesting thought to go to a pharmacy and say, I'm here to pick up my test strips. And you might say, hey, we noticed that you're using this. We think you may be eligible for something that we think might benefit you more. This seems very, very unique. Are there other conditions or other devices where you're doing something similar?
So definitely other conditions. And this is something that I think you're seeing it a little bit maybe in the chain space, but this is something that you will see very consistently in independent pharmacies, and specifically enhanced services pharmacies. There's a network of pharmacies across the country called CPESN pharmacies. And sorry for the acronym. If I have a chat, I'd put it in there, but it's CPESN, Community Pharmacy Enhanced Services Network. And they're all over the country. Pretty much every state, I think, has at least one. Some have a couple because of the location in larger states and so on and so forth. But these network of pharmacies specifically focus on providing these enhanced services, which focuses less on just filling a medication and putting it in the bottle and making sure people are consistently filling their medications and putting it in the bottle, which is important. But there's a focus of making sure that that medication that person's taking every day is actually doing the thing that we were wanting it to do. So if somebody's on a blood pressure medicine, a lot of what you see as far as quality performance metrics are focused on adherence. Is this pharmacy good at making sure that this person takes their medication every day? Yeah, that's all well and good. But if somebody's on a blood pressure medicine, but their blood pressure is consistently, running in the 150 over 95 or something like that, it's running really high. Well, that's not really doing the best job for that patient, because we know that we significantly reduce the risk of heart attacks and strokes when somebody's blood pressure is consistently below 130 over 80. So we should be doing something to help move that person to a better position, to get them to a point to where we know the research and the guidelines support that we are significantly reducing the risk of heart attacks and strokes, which is why we treat blood pressure in the first place. So we do that for blood pressure. Immunizations, that's something we very consistently do. If somebody's coming in for one immunization, we have our pharmacy management systems, and most independent pharmacies do, integrated with our state registry so that everything that's in their official record is pulled in, and I can quickly look up in my vaccine section of my patient's profile and say, hey, it looks like you're also due for this. If you want, you can get it today because I'm the pharmacist, I can prescribe that. Or if you want to just have a conversation with your doctor to, here's a list of the vaccines you're due for, you can go and talk with them and just come back here to the pharmacy and get them and get up to date in your vaccine. So in essence, what we're doing is trying to prevent, help that person get vaccinated against vaccine preventable diseases. We do it with many, many other things, but sure, that's kind of the general mode of all of the disease states that we're working with. We see that you're taking this thing. This is what it's supposed to do. Let's evaluate whether it's doing that thing. And if not, we need to be doing something.
For people listening, for those who don't have a Dr. Nichols, who don't have an independent pharmacy, who aren't sure where to begin, but they want a CGM, or at least they want to learn more about one, what kind of tips do you have? Like, can you give some advice to you went through so much red tape already. The way you had to describe it, right, was so complicated. I think it seems like a big challenge for people. Any advice for someone to just walk up to their pharmacy or talk to their doctor by themselves?
Yeah, I'd say always be willing to push and be persistent about it because, as I mentioned, especially early on, there were a lot of providers that in their minds automatically, because this person, and I'll just use Medicaid because that was a consistent one that we were working with. Because they have Medicaid, they didn't think that it was covered at all. So I can imagine a scenario if somebody were to go to talk to their doctor and they had that insurance, I could see them getting shot down as like, well, it's not covered, so we're just not going to even try to prescribe it. Talk to your doctor. Maybe you find one that has knowledge about the coverage. Talk to your pharmacist. I'm sure Chloe has a list of the currently participating pharmacists. These are pharmacies. These are probably, if you're in one of these areas, these are probably going to be the most likely to have success with this at this point. There will probably be others as well. But then also talk to whoever your insurance is. Give them a call and say, hey, I was wondering if you have this brand of CGM or this brand of CGM, and see if they cover it and how do I get access to this. Learn what the barriers are and work with your pharmacists and your doctors to try to get through those barriers. But I'd say the easiest would be talking with your pharmacist, but I'm a little biased.
As you should be. What about for folks who don't use insulin? Because it sounds like that's still a barrier. It's funny to say it that way, but what about folks who don't use insulin? Can they get coverage for CGM?
Yeah, they can. It's all going to come down to what your insurance covers. And now I will say that if you have the means to do it, you can always pay out of pocket for it. So that's something that it'll just come down to having a prescriber that would prescribe it. And, if you have a good relationship with your family doctor, usually they're pretty comfortable doing that, especially if they know that you're intentional without telling them that you're just going to be paying cash for it. Because some of the things that can come into play if they don't know that you're paying cash for it is, well, they're thinking in their back of their mind, well, I may have to go through this big, long prior authorization process. That can be a challenging barrier there. But I mean, if you're have the means, paying cash for it, that can be easier for you too. But then as far as if you do have insurance and you're going that route, it's going to come down to what your insurance has on their formulary, whether they'll cover this CGM or this CGM, and what that out of pocket that they're going to have for you.
I've also heard some of my listeners, especially on the Type 1 show, some of my listeners have had success talking to their employers, right? Whoever at this company is in charge of buying the health insurance or managing the health insurance. Quite often they're able to say, hey, I would like this to be covered. And that person can sometimes make it happen. Do you hear about stories like that?
I don't hear about stories like that, but I can see how it could be valuable because those are, especially those HR people, whoever's picking what plan their employees are going to have, that payer or those payers will be giving that employer options on what will be covered and what broad list of things would be covered under this plan versus this plan and how much it's going to cost that employer. So if that employer finds it valuable and they find that, their employees there's a large diabetes population, I can see them making a case for
gotta be
adding
lucky.
that coverage. Yeah. But I can see how that could be a strategy too.
I've noticed you've been very careful to never mention brand names during this interview. We've only got 2 standalone CGMs, I think, in the United States that you're prescribing, the Abbott Freestyle Libre and the Dexcom. That's what we've been referring to, or are there others that I'm missing?
Those are the main ones I've been referring to. And I intentionally don't say it because I don't know. I'm not 100% about the rules on promoting one versus the other. And I don't want to advocate because if you can find something that works for you, they're both great products. They have their benefits. Do whatever your insurance covers and works for you. But CGM in general is kind of the point for me. It's valuable for people and can be valuable if you can get access to it.
And I appreciate you not emphasizing one over the other, but I think it's important as people listen, if this may be the first time that they understand the brand names and the versions. It's really interesting, though, because I think I read last year that there are 36 different CGMs in production or in the pipeline around the world. We'll see what actually comes to market and what comes to the United States, but it's pretty interesting to look and see all of these different versions.
I would highly encourage people who have diabetes and historically have not had access to it. Don't write it off because things are changing. Things have changed in the past year. If you once thought that you didn't have access to it, definitely go back and start asking questions again because we're seeing a lot of payers follow after Medicare's lead, as usually happens. and starting to open up access. And I think there's a lot of different things in projects going around across the country that are demonstrating the value of putting more dollars and resources in the prevention of hospital visits. And I think this kind of falls into that. If we're able to better manage somebody's diabetes and better manage their situation, we can prevent those really expensive visits to the hospital that can be really devastating for a family who doesn't have a lot of means, but then it can be really expensive for a payer who's trying to, manage a lot of dollars to take care of a large group of people too. I think they're finding a lot of benefit in doing that.
And before I let you go, I would be curious. You say you're recent, right? You've been doing this for about 5 years, but I know that the process is a lot longer to get where you are. Why pharmacy? Why is this something you wanted to be involved in?
Well, it was a long road. I was what you would call a non-traditional student when it came to pharmacy school. So I did my undergrad work. And it's a funny story. I was actually originally on a path to be an actuary, was my original path. But talking with my providers, we kind of, counselors or at college, they're like, maybe we should, do something. I wasn't really loving the classes I was in. So we kind of pivoted to business management, really liked that. But I was traveling to Arizona to visit my aunt a few years back with my grandpa and my cousin. And she had just flat out dropped the question to me. It was like, so you're in business management major. Why or what are you going to do? And I work for a business, I guess.
Right.
I had no idea. And so she was in the healthcare field and she had kind of put that on my radar. And I worked with some of my counselors at college and they had basically said, well, there's a pharmacy is a growing business. There's a pharmacy in town that you could start working in. And as soon as I started working as a technician in a pharmacy, it wasn't a month. Seeing the interaction that pharmacists had with patients, how they were helping them, with diabetes, with blood pressure, with their inhaler technique and getting in control of their asthma and COPD. It was like, this is definitely what I want to do. This is it. And even as a technician, I felt like I was starting to get an expertise after working there for a while to be able to help patients myself, even, without the pharmacist's help and helping get prescriptions from doctors and things that they needed. And it was just this being able to be a servant to my community is just what I fell in love with. So I was very persistent about applying for pharmacy school and taking the tests and getting all the classes that I needed. And once I finally was accepted to the University of Iowa, that was all she wrote. I was all in, and I'm so happy I made that decision.
That's so cool. Well, I'm so glad I asked. Thank you so much. What a great answer. And thank you for doing this and serving your patients so well and going the extra mile here. Thank you so much for joining me. I would love to have you back. I got a lot of pharmacy questions we didn't get to, so I hope you'll join me again.
Yeah, thank you. I appreciate it, Stacey. Thanks for having me.
More about continuous glucose monitoring and the pilot program in the show notes. Just head over to diabetes-connections.com, click on the Type 2 show, and you should find everything you need right there. Helmsley Charitable Trust, by the way, is probably a name you're going to hear again around here. They do a lot of charitable work in the diabetes space. They fund a lot of studies, and I've talked to them many times over the years for Diabetes Connections for the Type 1 show. And I expect that they will be having an impact in the Type 2 space as well. Probably a good time to let you know that I'm also doing an interview with Dexcom, which may be up as soon as next week, about their Type 2 specific CGM. They just submitted Stelo to the FDA, that's the name of it. And it looks a lot like their G7, but it's supposed to have different hardware and software for people with type 2 who don't use insulin. So that interview should be up pretty soon, if not next week, then the week after. I'm looking forward to learning more about that. Thanks as always to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.